calcium channel gene, this is a sodium channel gene. Both of these are overrepresented in the bipolar population. So 20% more often you see variants at these genes in the bipolar population. Calcium and the sodium channel, is that enough to be diagnostic? No, right? So 20% association is certainly not diagnostic.
What was the percentage?
20%.
20%.
You find what in those variations?
So having a calcium variant or a sodium variant is more commonly seen in the bipolar population. Having this ADRA2A-G allele is overrepresented in the ADD population. Having MTHFR mutant is overrepresented in the autistic and the depressed population. Not enough to be diagnostic, but that's the direction we're heading.
What was the last one? Autistic?
MTHFR.
Oh, yeah.
I call it the mother.
Yeah.
You must have Stephen Stoll.
Mother.
Stephen Stoll likes to call it the mother.
Yeah,
So here's a little more genetics for you. So that, you know, there's three types of SNPs, right? You can have substitution. If I replace this G with an A, that's a substitution. You can have a deletion. If this C is removed, that's considered a deletion. One of the genes we look at, DRD2, the normal genotype is a CC. Those that have a C removed, it's considered a deletion. That deletion produces dysfunctional dopamine receptors. Or you can have an insertion. We don't really have any insertions on our panel, but it does exist where if you just stuck an extra G or an extra A somewhere in that chain, that would be considered an insertion. So here's a real world example of that. ANC3 is our sodium channel gene. The normal wild type is a C base pair in the sequence. If I yank out that C, replace it with a T, that produces dysfunctional ANC3 protein, and ANC3 anchors sodium channels in the nodes of Ranvier. So that's where they need to be, because if they're not anchored at those nodes, then you're competing with the myelin sheath and you don't get normal neuronal transmission. So that single base pair substitution makes screwy proteins.
So you would use a mood stabilizer?
Yeah, that's what, so if you had that variant, we know that it's associated with bipolar and schizophrenia. Not as strong as in schizophrenia, but certainly in bipolar. So, the idea here is we know they have abnormal signaling. They're hyper-excitable neuronal signaling. Let's reduce that signaling somehow. All of the mood stabilizers do that. Fish oil does that. And the atypical antipsychotics all reduce glutamate, which reduces that signaling also.
Right. I just want to add to the group that they're also looking at complementary medicine, you know, like fish oil and some other things. And that's important as Psych NPs, where you have a little bit more of a holistic approach. And there were a few that were also looking at psychotherapy.
You know, we'll look at the study that was done with fish oil here. Fish oil works as an antidepressant for bipolar or unipolar depression. The trick is you have to have more EPA than DHA. So if it's at least 60% EPA, it was effective at treating both types of depression. And I have a graphic here that'll show that. So all this genetic information is good, right? It's important, it's valuable. Do not underestimate the environmental impact here. You know, I have a lot of clinicians that say, okay, they have a calcium channel variant, they're bipolar, right? I'm just saying, no, that's not the way this works. All these genetic variants are just risk factors. Here's an example right here. This is meant to represent depressive symptoms based on childhood trauma. As you would expect, as childhood trauma increases, rates of depression also increases. But then what if you add on top of that some genetic data? This is the MTHFR mutant right here. If you are a heterozygote or a homozygote, you have higher depressive symptoms with the same amount of childhood trauma. Okay, so there's clearly an interaction between your genes and your environment. Never underestimate the environmental. Don't overestimate the genes is what I'm trying to tell you here. The information is valuable, but you can have short patients that respond fine to SSRIs. If that's what you're seeing clinically, great, leave it alone. But probabilistically, they're not going to respond well.
Dan, can you go back to that slide and just explain to the group the MTHFR? Because, I mean, you know this stuff well, but I know the class, and I could see that they need a little bit more explanation.
Yep, so I'll go into it anyway, but I'll give you just a sort of head start on it. So MTHFR is responsible for folic acid conversion. All the folate you get in your diet needs to be converted to methylfolate. The enzyme that does that is MTHFR. Now the value of methylfolate is it's the version that crosses the blood-brain barrier, and it helps produce catecholamines, norepinephrine, dopamine, serotonin. If you have dysfunction at MTHFR, you don't convert enough of your methylfolate, puts you at increased risk for depression, bipolar, and schizophrenia. Okay, so the trick here is if you're not making your own methylfolate, let's supplement you with methylfolate. And whatever methylfolate product you like, whether it be Deplin, Enlite, MethylPro, Metinex, whatever you like, those that have the variant there benefit from methylfolate substitution. And methylfolate has been shown to boost the efficacy of SSRIs and SNRIs and to treat depression independently. So here's another gene-environment interaction, right? Look at this. This is outrageous here. Number of stressful life events compared to those that have the short gene versus the long gene. If you're short, look at your incidence of suicidal ideation or a suicide attempt compared to the long, right? Yes, stressful life events increase your suicidal ideation if you have the long gene, but it really does it if you're short. And you see how it's cumulative? One short allele, increased risk. Two short alleles, much increased risk. All right, so P450s, you like those? Pharmacokinetics. So to me, this is the more boring stuff, more straightforward stuff, but let's cover it anyway. Here's your P450 families. 3A4 is the big one. About 50% of drugs are broken down by 3A4. 2D6 is the second biggest one, but 2D6 has a much greater impact within psychiatry. Most of your SSRIs, all of your tricyclics, half of your SNRIs, half of your atypicals, all go through the 2D6 pathway. So it'd be important to know whether your patients are going to over-metabolize or under-metabolize these drugs. And so here are your possible variants here. You can be a poor metabolizer, intermediate, extensive, which is considered normal, that's baseline, and then ultra-rapid. These are your fasts, these are your slows, and these are your real risk variants right here. If you're an ultra-rapid, you are more likely to be a non-responder to medications. You break it down so quickly, you tend to be non-therapeutic. If you're a poor metabolizer, you break it down slowly, increases the blood levels, tend to have more side effects. We're right in the middle of our study with Dr. Mago at Jefferson in Philadelphia. He has 100 patients in so far, and it's crystal clear that poor metabolizers have far more adverse events to SSRIs and SNRIs if they're poor metabolizers.
That's even at lower doses, lowest dose?
Yeah, so that's the trick. Underdose them if they're poor metabolizers, because at normal starting doses, they're going to have higher blood levels. And with poor metabolizers, it's almost double, and in some cases, it's 6 times. If you give a Strattera to a poor metabolizer, their blood levels can be 6 times the normal blood level. With something like Paxil, it's probably double. So, 10 milligrams of Paxil is really 20. In fact, the FDA got involved with this. They said if you are a poor metabolizer at 2C19, don't go above 20 milligrams of Celexa. So you guys are smart. What does Celexa do at high doses? What does it do to your ticker? Yeah, QT prolongation. So if you're a poor metabolizer and you're not metabolizing citalopram, don't go above 20 milligrams because you put your patient at risk for QT.
And what enzyme breaks down citalopram? Oh.
CYP2C19.
So here are the different families. Here's 2D6, 2C19, and 3A4. 1A2, 2B6, 2C9. 2B6 is a pretty small family. It really only breaks down Wellbutrin and methadone. 1A2 is pretty interesting. So it breaks down a lot of medications. But 1A2 is a highly inducible enzyme. It's the most inducible of your P450s, right? Guess what induces it? Smoking, cruciferous vegetables. Anybody on a broccoli diet? Or if, God help your soul, if you like well done meats, that also induces cytochrome 1A2. So this is by far the most important. Smoking can triple the 1A2 blood levels. So this is valuable here. Let's say you have a patient on Cymbalta, goes through the 1A2 pathway. They decide to start smoking a pack a day. What's going to happen to those Cymbalta blood levels? They're going to go down. Yeah, you're going to hyper-metabolize that drug now. All of a sudden, you start smoking and you're depressed. What happened? I don't know what happened. Well, you started smoking, you've induced that enzyme. Now your Cymbalta levels are way down here.
Mhm. Dan, before you only did 3 enzymes,
6
right?
now, yeah.
So before it was 2D6.
2C19
Okay.
and 3A4.
Okay.
We just added 1A2, 2B6, and 2C9.
What did you add? I'm sorry, 1A2?
1A2, 2B6,
Okay.
and 2C9.
Okay. So you had said earlier that the 3A4 was more prevalent than the 2D6? What?
So within all of the FDA-approved
Yeah.
medications, 3A4 accounts for 50% of those medications.
Okay, but not the site.
Within psychiatry,
It's more
2D6 is more
2D6.
important.
Okay. So you remember 2D6 was your SSRIs like Prozac and Paxil,
Yeah.
but the 3A4 is also citalopram and escitalopram.
Yeah, so in our report, it would look something like this. Here's all your drugs. Here's the primary metabolism family and the secondary metabolism family. So citalopram, primarily 2C19,
Okay.
and a little bit 3A4.
Okay. Leave that up a minute, I just want to. And you do get that in the report.
Yeah, so let's say, in this example, this person was a poor metabolizer at 2C19. Well, we tell you that drug levels may be increased in this patient because they're a poor metabolizer. In addition, they were short for the serotonin pumps, which predicts poor response to SSRIs. So we tell you here, be careful with SSRIs. They're not likely to respond to them, or lower response rates.
So it really gets tricky if somebody, say, is on trazodone, which is a 3A4, and then they eat a lot of grapefruit, which inhibits the enzyme. So you can really have a major problem there.
Yep.
Correct me if I'm wrong.
No, you nailed it,
Okay.
right? Grapefruit juice is a pretty potent inhibitor. The reverse of that would be Tegretol. Carbamazepine is a
Which-
potent inducer.
Yeah.
What's the turnaround time on this type of exam, this
3
test?
days.
3
About
days?
3 days, yeah. So we're in Philly. King of Prussia is our home office. So this, around here, 3 days.
And is there a good way to look at, like, if you have a particular clinical question that you want to know, is like this test gonna answer for you? Do you just call you first? Okay.
Yeah, so I cover the
Because
whole.
it has so much information, it seems like it's a little bit of like a needle in the haystack, like.
Yeah, so the first thing I would, what I usually tell new clinicians that use that test, here's all of our educational material, read it, orient yourself to the language of the report, and then you're still gonna have questions, so give me a call and we'll walk through it.
We're using this predominantly for adults? Is there an
No,
indication?
25% are
No,
kids.
I use it on kids, yeah.
Now, most of the dosing recommendations are adult dosing recommendations, so, you know, we stay away from that in the pediatric population. We let the clinician figure that out, but yeah, a quarter of our tests are kids.
The right column, it seems to say, why is it both? Increased risk for adverse events, which would be increased serum levels, and then poor response, meaning low serum levels. How could it
So
be both?
you have 2 genes that interact with this particular drug. The short gene tells you that they are unlikely to respond to any SSRI.
Oh, so it's depending, so there are 2 outcomes.